not sold separately, so keep them together. The only thing I had to put together was the Salter cup. It was inside the circuit bag, but in a bag by itself. So I just attached it to the rubber and I put the gas source right at the bottom. That's all I had to do. The circuit only goes on one way, so this little nub that's sticking up here, I call that a key, and right here into the interface is a hole. That's my key hole. And as you can tell, it aligns at an angle, so you want to align it and then just turn it up clockwise so that the arrows are straight up. You don't want to over twist because you can break off that little key. Same when you take it out, counterclockwise, pull it straight out. So it's meant to be stored in the patient's room, and the MetaNeb itself can be wiped down and taken on to a different patient. So we put this back in. The manufacturer asks that we do a pre-check use prior to every use. And you do not have to memorize it because attached to your MetaNeb is actually instructions on the pre-use check. And then on the back side, how to do the treatment for a spontaneous breather, as well as how to do it in line with the ventilator. So pre-check use. I've already hooked it up to my oxygen. I'm gonna start up here at CHFO, and I'm gonna start out on high. I'll talk a little bit more about this in a moment, but I'm gonna turn my expiratory resistance up to the highest, which is 3 dots. I'm gonna turn it on. I'm in the patient's room, so I'm probably gloved up. I occlude the mouthpiece, and what I'm looking at is the manometer needle. I don't want my needle less than 15 or more than 30. Then I turn my CPEP, continuous positive expiratory pressure, flow all the way up, occlude it one last time, and here I want my needle not less than 20, not more than 30. I'm right on. So again, those parameters I talked about, you do not have to memorize. They're right here for your review. What happens if I'm out of parameter? Well, then I get a new circuit and I test it. Typically, that's what it is. This happened to me before because I carry a circuit around with me all the time, and generally after several months, they do go bad. But when you're using it every day with the patient, that's why we do the pre-check use, to make sure that it's still viable. Again, get another circuit if it's out of range and test it, and you should be good to go after that. But if for some reason after the second circuit it's still out of range, contact Hillrom. We'll replace your unit for you. Okay, so now we're ready to talk about getting it ready for the patient. So that expiratory resistance I was talking about, the blue ring is actually covering this hole partially to make our resistance. So we have a 1 dot, 2 dot, and 3 dot, 1 being the least, 3 being the most. For my new patient who's never used MetaNeb before, I always like to start in the middle at 2. That way I have a place to go. So if at 2 the patient's struggling, I can say let's make it easier and go down to 1. Or if they're doing a fantastic job, let's challenge you, go up to 3. So remember, in the bag of adapters, you have a mouthpiece, and you also have actually 4. You have 2 clear adapters. Those are for spontaneous breathers, whether it be the mouthpiece or whether it would be the adapter that would help attach a mask or flex tubing for the trach. And then you have 2 non-clear adapters. Those are definitely what you'll use for the ventilator. So attach your mouthpiece. It's at 2. We're going to put our medicine or saline in the cup. We're going to hand it off to the patient. Turn it on. We're always going to start down here at CPEP for the spontaneous breather. And I'm going to adjust my flow for the first time, if this were a clock, to about 5 o'clock, because that gives me an average of a 6 to 10 PEP to start with. But you can start anywhere you want, knowing that even if you start at the really highest, you're not going to do any harm. Okay? So that's just a good starting range. So we hand it off to the patient, ask them to keep a tight seal, breathe in and out through their mouth for about 2 minutes. After 2 minutes, we warn them we're going up to oscillation. Here, a lot more coaching needed. Tight seal, keep the cheeks in. Big breath in, big breath out. I always start at high. Research actually tells us that patients tolerate high or better, but if they didn't like it, you have a place to go down to low, okay? We're going to do this for about 2 minutes, and then we're going to go back down to expansion, give them a break from the oscillation. We're helping keep those airways stented open. We're going to do this for about 2 minutes, and then we finish up back up here at CHFO. So basically you're done when your medicine's done, and that's just an average about 8 to 10 minutes. It just depends. So after that 8 minutes, if you still have medicine in your cup, you can choose to do another round or concentrate on the treatment therapy that your patient needs most, whether it be the oscillatory or the expansion, or if you have to. This icon right here is straight nebulizer. You could finish out your medicine on straight nebulizer, but realize that you're not getting any benefit of the expansion or the oscillation when you're doing the neb. So whether you're using a mouthpiece or a mask, and again you use that clear adapter that came in your kit, you would supply the pillow type bamboo mask that would attach directly to that, and then of course to the patient's face for a tight seal. You do it the very same way, alternating back and forth. Or whether that patient has a trach, you would supply some flex tubing that then would attach directly to their trach. Do it the very same way, alternating between CPAP and CHFO. Head and bed at 30-degree angle if it's not contraindicated on all these treatment modalities. So the last one we need to talk about is inline with the ventilator. Inline with the vent is actually the easiest. The patients are the sickest, so you're getting more bang for your buck. Typically they have a chest x-ray every 24 hours, so you can actually view what's going on and how the patient's progressing. So the first thing I need to do is take that blue ring off and put the black ring on. So I told you that there were the two non-clear for the vent. So I'm going to put the black ring on. I'm going to make sure I get it on right, because we want to cover that hole completely, but you can easily get it on upside down and not realize it. So double check your work. Then you're going to use your non-clear adapter. You're going to put a T-spring loader in the inspiratory limb of your ventilator closest to the Y. We don't supply those. You'll get that from your own supply kit. I love doing it on a vent, again, because it's easier. Because if you think about it, your vent is already doing your expansion mode. So we're just going to keep the dial up here at CHFO always on high. I'm going to put my medicine or saline in the cup. I'm going to turn it on first. Then I'm going to place it into the T-spring. Cup upright so it runs better. And I'm just going to let it run. So when you're finished, which will be whenever your medicine's done, pull it out first, clamp it off, shut it off so we don't lose our recruitment. Now your ventilator is going to go crazy when it's not going to recognize where we're adding, where this extra volume and pressure is coming from. It does run best on a pressure setting. It does well on a volume, although you'll get a little bit more alarms at that point. If it's on a trigger mode, you'll want to trigger flow, change that out so it doesn't auto cycle. Most therapists just silence the alarm during the treatment, but you can change the parameters so it doesn't alarm. You just need to make sure you change them back when you're finished. It will pick up those oscillations as respiration, so you'll see a lot of that on your screen. Always remember to look at your patient's vital signs and oxygenation. You'll see that they're very stable. Again, head and bed at 30-degree angle. If it's not contraindicated, I've certainly seen a lot done flat, just because the patient could not set up. What else do I need to tell you, Dave? What am I
have a question.
Yes.
When it's in oscillation mode, is that flow button active at all, or is that not?
No, very good question. So when it's in CHFO, the flow button does nothing. The flow only works when it's in that CPAP mode. And then up here for CHFO, high and low only go with it. Doesn't do anything otherwise. Good question.
And when we use the MetaNeb on trach patients, the cuff can be up or down on spontaneous breathing trach patients?
Exactly. Hillrom doesn't make a recommendation one way or the other. Remember that they always have their expiratory hold because a blue ring is on, but that would be something you guys would decide on your own whether you want to make a change to your policy on cuff up or cuff down.
Okay.
As far as when do we know that the patient's doing better? When is it that we should move on to a different modality? So the MetaNeb's not for everyone. You know, we talked about those patients with open heart, anybody with thoracic, abdominal surgery, any traumas, any patients with neurological, muscular disorders, CF, chronic pulmonary diseases are perfect candidates for this. But there's time and place that they should move on to a different modality, and hopefully a modality that maybe they can even take home with them if they needed to prevent readmission. So when the chest X-ray is clear, when you're getting less than 5 cc's of secretions per treatment in a 24-hour period, probably time to move on, and breath sounds when those are clear. So you know, we know that it takes a 10-minute treatment time, which is a lot of your time at the bedside, but it isn't meant for everyone or every treatment, and hopefully we're getting the patients better faster, preventing bounce backs to the ICU, re-intubations, and 30-day readmissions. We've proven to decrease length of stay on the vent by 1.5 days and total hospital days by 2.
And circuit per patient, is there a time that we need to change that out if we have a patient that's been here for a while?
Oh, thank you, yes. So the circuit lasts 7 days or approximately 30 treatments. So I like, once I open it up, to mark the bag so I have some sort of indication. But again, that's why we do the pre-check use, because depending on the type of medication, if it's stickier, you might go through them a little faster. Or if you know your patient's, you know, been here 7 days, but the circuit's still good, there's no reason why you couldn't get a few more days use out of it as well.
Okay. Any
Good
questions?
Do you have to do the check every time?
That's what the manufacturer recommends. Yes.
Any other questions? I'm good. Anything else?
No, thank you so much.
Thank
Appreciate it.
Thank you.
Thank you.
Mhm.